The walls of the ventricles are supplied by three main coronary arteries, which are the left main coronary artery, which divides into the left anterior descending artery, the left circumflex artery, and the right coronary artery. This is the left anterior descending, left circumflex. The left anterior descending, as you can notice, it supplies the anterior portion of the heart. So let's say this is the anterior portion or the anterior wall. Thus, this is the posterior wall. This is the septal wall that separates the right from the left ventricle septum. This is the lateral wall of the left ventricle, and this is the right ventricle wall. The left anterior descending artery, it supplies the anterior wall and the anterior 2/3 of the interventricular septum. The left circumflex, it supplies the lateral wall, and the right coronary, it supplies the posterior wall and the posterior third of the interventricular septum and the right ventricle. So ischemia that happens in any of these vessels will affect the corresponding wall that it supplies. So let's say about what happens in anterior myocardial infarction when the left anterior descending artery has been occluded. How does it manifest with anterior ST elevation? MI, how should we recognize this on the ECG? Anterior ST elevation, that also definitely this also depends on the location. Where did it occlude? Did it occlude? The MI happened, and the occlusion has happened very proximal in the LAD, or in the mid LAD, or in the distal LAD. As you can notice that this is the anterior wall of the MI, and part of the septum is supplied. How does it manifest on an ECG? With very proximal occlusion. If the occlusion is very proximal to the first diagonal, this is the diagonal branches, and those are the septal branches. So if it is a very proximal occlusion, it will result in anterior ST elevation, with ST elevation in all the leads from V1 to V6 with ST elevation. You should also recognize that ST elevation myocardial infarction, they are associated with what? They are associated with Q waves. So how we define this is ST elevation due to a myocardial infarction rather than it is a pericarditis. We say that the presence of the Q waves is very important. Also, they present as the diagonal branch. It supplies the high lateral wall. We might find an ST elevation in AVL and V1. Reciprocal changes can be found in the inferior leads. And this is an example, real example. This is the left anterior descending, very proximal occlusion. This is the diagonal branch. Those are the septal branches. So if this artery has occluded, this ECG will manifest with anterior ST elevation on V1, V2, 3, 4, 5, 6, and also leads V1 and AVL as the diagonal branch has been affected. When the diagonal branch is affected, this is called the high lateral myocardial infarction, and it will result in ST elevations in lead 1 and AVL, as you can notice. This is an ECG from a diagonal branch that supplies the lateral wall. The involvement of the diagonal will cause ST elevation in leads V1 and AVL. Reciprocal changes will appear also in the inferior leads. They can appear in the inferior leads. And don't forget that also the lateral wall is represented on the ECG on leads V4, 5, and 6. So you might also find ST elevation in lead 1, AVL, and also in leads 4, 5, and V6. This is called the South African flag sign, where you can find ST elevation in lead 1, in AVL, and even V2, with ST depression in the inferior leads of 3 and AVF. This is called the South African flag sign that represents a large first diagonal branch occlusion. How does the right coronary artery occlusion, how does it manifest? It supplies, as we said, the right coronary, it supplies the posterior wall of the heart, the posterior interventricular septum, and the right ventricle. How should we discriminate this? We should discriminate this by the presence of an element of inferior ST elevation. But the most important, how to recognize posterior MI on an ECG. You should see the following. You should see a horizontal ST depression in V1, V2, and V3. Horizontal ST depression V1, V2, V3 with a prominent R waves or an R wave that is taller than the S wave. This is the most important clue that this patient is having a posterior myocardial infarction. Posterior myocardial infarction. So what's the next step? If you think that this patient is having a posterior myocardial infarction, I need to assess the leads V7, V8, V9. I should put the leads on the back of the patient in this position to wrap around the chest to continue the leads, putting them on the left side, and then to continue V7, V8, V9, and this, what will I get? I will get, this is the same ECG with an element of inferior ST elevation, horizontal ST depression, tall R waves with R waves more taller than the S waves, but with ST elevation in V7, V8, and V9. You can see the ST elevation here. Regarding how to diagnose ST elevation in patients who already have left bundle branch block, and here we depend on the Scarbossa criteria, which will we discuss now.